So thank you for the invitation. I'm very happy to be here in Vancouver. So I'm going to be lazy and I'm going to use nomenclature, the test and treat nomenclature to talk about the usage of antiretrovirals for in treating people who are positive in terms of stopping transmission. There's lots of other synonyms which are test and offer and treatment as prevention, but I'm going to be using that throughout my presentation. It took me, when I was presented with the 1990 guidelines, I think I had spent a few months grumping about yet another Geneva agency giving us yet another target and another soundbite. But actually, when you look at the 1990 targets, I think it's a very useful framework for us to start looking at how we are going to tackle getting HIV under control. And I think this allocation into these discrete 3 boxes actually helps programs to start focusing on what's really important. I must, in terms of, sorry, just battling a little bit with this. So these are the acknowledgements, mainly the people whose slides I stole, my declarations. The most important declaration probably is that I'm a clinician who's been dragged kicking and screaming into the prevention world. My boss, who's a very long-suffering boss, who is a prevention queen, has to deal with my kind of sort of the way I've had to deal with over the years of dealing with prevention programs, which I found very frustrating actually, and I'll show you some of those frustrations. And that includes test and treat and as a mechanism of prevention. So this is the newly released AVAC report, which demonstrates a dramatic increase in investments in prevention research. And what's heartening about this is a lot of that investment seems to be coming from internal sources. What's also heartening is that most of it is focused within Southern Africa, where the epidemic is still cited. So what do we have to talk about? We obviously have test and treat. I'm only going to be talking about the 4 in bold. I don't want to neglect all the other areas, but I think that people are well aware of what else is available. Post-exposure prophylaxis, or PEP, is a very useful concept in terms of transitioning into pre-exposure prophylaxis and PrEP. We often see people who come forward for PEP and then require PrEP in these programs. So that's where it sits. As a public health intervention, I'm not convinced it plays a huge role. Male circumcision programs, kind of an orphan prevention program, I'd argue. And then I'll be touching a little bit on behavior change. I'm not going to be focusing on the stuff that's in the future, and I think Richard Jeffries here put it really, really well about the fact that the science is very, very fragile around both the cure as well as in terms of the vaccine, although I'm told from the vaccinologists that there's a great amount of hope, and you heard earlier that cure is there. There's also a new deprivaline ring microbicide which may be available very soon. So let's start with treatment as prevention. I'll give you a very rapid history of what happened here. It's been the theoretical and observational data underpinning treatment as prevention has been around for a while. It starts with Tom Quinn demonstrating that viral load is correlated with infectiousness, and we've seen this in all sorts of other prevention scenarios. Julio Montano, who I think we all acknowledge has been one of the forerunners in terms of promoting treatment as prevention, put forward demographic models a decade ago, mathematical models. For myself, I think this one that came out, this very provocative paper from Ruben Grange, which was published in the Lancet in 2008, even though there was a lot of criticism of some of the assumptions underlying it, the fact that it dealt with South Africa and eradicating HIV was the first time I think that I certainly was getting my head around the fact that there might be a way of dealing with this. Then we had all the observational studies following, and again, British Columbia has certainly led the way, and Julio's team, where they've demonstrated a close correlation with treatment saturation and a decrease in HIV incidence. In San Francisco, they've done some really nice, they've got a really nice database where they've demonstrated the number of cases going down as the community viral load came down. But for me, again, what was most striking was the science paper that Frank Tanz and colleagues from the Africa Center put out a couple of years ago, which demonstrated that if you increase treatment saturation by just 1%, you get a 1.7% incidence drop. What's not appreciated often about this paper is that the CD4 count initiation threshold at the time, for almost the entire period of the study, it was only 200. And it only became 350 a little bit towards the end of the study period. So all this benefit that we saw was actually in a situation where people with very advanced HIV were being treated. So, have we made sex safe? And I think Mike Cohen and his 052 team have pretty much said yes. You know, if you can get your viral load down to undetectable, you will not transmit the virus. And for this conference is amazing because exactly 4 years ago we were exposed to that data, and I think it's pretty much changed the world. We've had the partner study, which is an ongoing study that, as far as I'm aware, has yet to describe a transmission of HIV. In the partner study, all that was provided was the positive partner in discordant relationships was provided with antiretrovirals. The negative partner was not, to be enrolled in the study, was not supposed to be accessing any form of HIV prevention. And again, the fact that this ongoing study seems to demonstrate that the incredible power of these drugs in terms of stopping transmission when you treat the positive partner. The problem, and this is for the last 5 years that I've been heavily involved in this area, is what we fight over, whether it's over dinner or in fora and is it's all very well to treat somebody with HIV to stop transmission to other people, but what about the individual benefits? And this is what we fight about, is the believers all say it's absolute rubbish, you don't want this virus running around your body. The non-believers say these drugs are toxic, there's a lot of adherence required, what about the long-term resistance? There's a whole lot of people sitting on both sides, and a lot of the observational studies are actually quite conflicting. And 052, which showed the benefit was very, very small. And I'll talk about why that might be. And even the study which was presented in the last 2 weeks in the Lancet, the causal study, suggests that in the rich countries, the benefit is very small. And to quote Brian Gazzard, a very opinionated British researcher, he talked about test and treat as this, I think the words were expensive public health adventure that people were pushing for. But now we've got 2 randomized controlled studies, very different studies, which are hopefully going to be published in the next week or so, which have fixed this. We both showed remarkably similar results as kind of a halving of serious risk of morbidity and mortality. And these studies, I think, are well-conducted studies. The START study was absolutely massive and has shown statistically significant benefits. And I don't think I've met a single person that has contested this. Having said that, there is a certain amount of triumphalism that's come with the people who were proved right. And David Barr put this really well, is that the reason START and Temprano worked so well, and maybe why 052 didn't, is we had safe drugs. We were not using the old drugs, D40 and AZT, and if we'd used those drugs, as he puts it, we may well have had a very different result in both those studies, but we had tenofovir, which is very safe, and which did the trick. The other thing I just want to point to you, which I don't think has been appreciated enough, Temprano was done in Côte d'Ivoire, a very poor country. START was done in largely in middle and higher income countries. Very, very well conducted study. If you look at the data, the serious event, and I admit it's crude comparison, but if you look at treated people in the Temprano study, people who started ARVs at a very high CD4 count, their event rate was twice as high as untreated people in the START cohort who were treated. And for me, that is something we have to think about. Is it because people are poor? Is the benefit of antiretroviral therapy largely realized in poorer countries, which does come to the heart of some of the recommendations I'm going to come to later. The good news is that our programs are improving, and certainly in South Africa, thanks to Andrew Bull for these slides, that the proportion of people testing and initiating ARVs is going up and up and up as the programs mature. And even though in 2010 we went from 200 to 350, and that's why you get that bump, you can see a steady increase in the proportion of patients starting over 200. With it's come a fairly dramatic improvement in life expectancy, and very hearteningly, for the first time we've seen, even though there was a small lag phase from this NHLS database, this decrease in tuberculosis, which for us is still front and center part of the epidemic. I was very privileged to be part of a UNAIDS meeting 2 days ago, which looked at a whole lot of these test and treat projects. And you can see from a host of countries, people were standing up and presenting massive studies where they're going in and different interventions in different ways, getting people tested, getting people into care, initiating therapy. In the MaxArt project, showing remarkable levels of acceptance of starting antiretrovirals on the same day. Within the Africa Center, getting lots and lots of people to test. Within the Search project, just putting a package of care that seems to be incredibly acceptable. So there's going to be a wealth of data out of these studies to demonstrate what we're going to need to do operationally as we're going forward. And Tim Maestro put it very well at the end of the session. He says that's over 1 million participants in these studies. That's a lot of information that we're going to have to take on board and listen to as we go forward. So, problem solved. We've now got test and treat. We can all go home. HIV is over. We kind of have to genuflect to all these prevention things that are out there now. And what do we have? Well, the important thing to remember is that I think sometimes prevention, people involved in pure prevention will forget that their prevention interventions also exist within a context of care. HIV treatment provision exists in the context of care. Whether you're accessing PrEP or whether you're getting a vaccine, it needs a care delivery system that needs to be effective. So that context of care is important, and it involves the cost of the intervention. That varies, obviously. What's the inconvenience of accessing that intervention? What are the side effects of that intervention? They all have side effects. And finally, what's the stigma attached to the intervention? I'm going to talk about that a little. So let's talk about PrEP. This really is the new thing on the block. It's kind of commanded headlines across the board. And for me at CROI, one of the most electrifying sessions I've actually attended occurred earlier this year, where the sort of early PrEP data was kind of, the demonstration data was shown to work incredibly well in the real world. In fact, far better than in the demonstration project. And in fact, the higher your risk, it seemed, the more likely you were to actually take those drugs. So PrEP certainly has, as I said, electrified us. The studies are a whole lot of things. It debunked the issue of risk decompensation, which we've seen again and again and again raised around HIV biomedical prevention, and again showed that it was nonsense. It showed also that these men, particularly the gay men in the studies that were studied, that condoms just were not enough. They had incredibly high incidence rates, and that PrEP cut that by close to 90%. The other thing which I think the data has demonstrated increasingly is that resistance is not really an issue. It seems to be something we all have to wring our hands over for a while, but that it seems to be pretty good. And we're wondering how much of the toxicity monitoring is required to make this get into the field. One of the things that does strike me, though, is that the coverage of PrEP, despite all the headlines, is extremely limited. And a lot of that is related to the cost and programs having to face up to the fact that the treatment here in British Columbia is 50 times the cost of a place like South Africa, and is prohibitive to many, or is seen as prohibitive by many programs. But there is, I think, a very strong advocacy movement, as demonstrated by this Lancet article editorial, which says to take it forward. What about male circumcision? As I said, a bit of an orphan. Exactly 10 years since we were at this conference and the Orange Farm data was put forward. We know that now that the data is sustained. We've seen it in lots of different projects. And in 2014 alone, in 14 priority African countries, over 3 million men were circumcised. And if you look at that, it's a 750% increase from 2010. And this is one of the only things we have that actually get men into services. We're still seeing that men are disproportionately under-tested in Southern Africa and entering antiretroviral programs in smaller numbers and at a later stage. This is a really impressive piece of work from AMFAR, where they've taken all the PEPFAR COPs and withdrawn all the funding and charted how the money is being spent. And this actually demonstrates that within PEPFAR, worryingly, there is a slight decrease in money being available for circumcision. And I would argue that here you have an established intervention that actually does work. Why is now the time that you're pulling back? And it would be a mistake, I think, to continue to do that, and hopefully that won't continue. Let's do a thought experiment, though. Let's say you're a cold-hearted public health official, you're a minister of health who doesn't really care. Let's get rid of all that nonsense. Let's aggressively fix what we've got. We know we have to test everyone for HIV. Let's go hunt them down and let's put them on treatment, okay? And let's make the system better. But why just not prevent when it's so much easier? And you know, when you look at these numbers, which were, this is the economists putting it forward, it's actually quite difficult to argue against. So does it make sense? Well, you have to fix the current health model. All you have to do is take it and improve it. We know and we can see that these demonstration projects, if you do pour energy into it, you can get people to test and to enter the system. You also don't have to waste your money on all this dubious behavior change stuff that seems to come up again and again and again. I'll touch on that in just a moment.
There's no more complicated vertical programs. And these are very unpopular within no more discussions about treating 17 people to stop one and having to get your head around stuff like that. And finally, all those pesky gay men and those sex workers and those IDUs and all the people that, for politicians and for program managers are really difficult to get to and make their lives very uncomfortable. You don't need to worry about them anymore. So, I can see some as I said, some cold-hearted public health people thinking, gosh, this is like manna from heaven. The problem is that we know from umpteen mathematical models that you have to do it all together, that just simply going for the drugs is probably not going to do the trick. And this Tim Hallett's annoyingly prolific group has managed to demonstrate again and again and again that you need to do this in combination. And UNAIDS has released this rather alarming thing, demonstrating that if we just continue doing what we're going to do, we're just going to kind of be chasing our tail till the end of time. But importantly for test and treat, you have to get virological suppression. It's the premise of the entire theory around it. And this study which demonstrated that that magical number of about 1,000 to 1,500 is what we need to be aiming for, is what we've got to get our head around. And the Achilles heel of treatment as prevention and test and treat programs is the issue of retention. And you've all heard about the cascades, and I'm going to show you some of that data now. But for us to fix this, to get this right, we really are going to have to fix this. And the problem is that we're implementing, often, certainly in my arena, in a health system that's not friendly, that's very unreliable, and which is not that trustworthy when it comes to providing care. It also relies on a massive industry that is global around the drugs and the manufacturing that goes into them. This amazing data from Andrew Hill, he's presenting something similar a bit later today, and I'd urge you to go and see it, demonstrating this cascade of care across the world. And I watched a very spirited, I think the word is, argument between Mike Cohen from the US and Sarah Fiddler from Britain about why Britain hadn't gone to a CD4 count of 500 or removed the CD4 count threshold completely. And Sarah was trying to defend, and you have to understand Mike to understand how hard that is, that why Britain hadn't actually got there. And if you look at this, which is Andrew, again, he's demonstrating the suppression rates. If I was a patient and I could choose which of those two countries I'd like to live in, you can see here you really would like to live in Britain rather than the US, because despite the fact the US has much more aggressive treatment guidelines, or until recently, Britain provides much better context of care, and therefore your viral load is much more likely to be suppressed. And this demonstrates, again, Sydney Rosen and Max Fox have been doing amazing work since I've been involved in the HIV area, looking at retention in care. And you can see that one of the biggest problems we have is tracking patients that get lost to the system. Most of us think this 30% loss at 3 years that's quoted a lot probably is a gross overestimate, but we just don't have the numbers to be able to tell that. This shows the South African program, and what you can see here is retention in care gets worse at the site that they were initiated at as the program matures. And this might be because we're treating everybody, we're treating a greater number of less motivated patients. Also, maybe the programs are just less motivated to actually provide the adherence that's required. What's interesting about this study, again from Sydney's group, is that there's a huge amount of heterogeneity in terms of retention in care. And this is actually relatively good news, because it suggests to me that this is not intrinsic to the patients, this is intrinsic to the healthcare system, and that Uganda model at the top there is something that we all should be aiming to and should be able to achieve if we track our patients correctly and if we treat them properly. So what about this treatment? Well, it's treatment for life. And I think that's something people forget, is that somebody is going to be putting their hands in the healthcare system for the rest of their life. As you heard, the life expectancies return pretty much to normal, in some studies even higher, greater than normal, and that is something they're going to have to deal with. In South Africa, we have drug stockouts on a daily basis across the country. One of the richest, most sophisticated countries. We ran out of our major protease inhibitor last week across the country. We have nothing to replace it with. You are now saying to people that you must put your hands, you are literally putting your life in their hands. And it's not just in South Africa, it's across the world. Certainly in South Africa, when we've done the analysis, 80% of the drug stockouts are actually related to systemic problems and supply lines, but 20% of them are actually related to drug companies or manufacturers not being able to meet their obligations.
You're also relying on a massive international industry. The raw chemicals that go into these tablets is huge. And I was talking to somebody from my land who was saying that the 30 million people we're looking to put on treatment has never been done before by generic manufacturers. That it is a huge challenge. So India alone is providing 80% of the generic ARV market to our various countries. And again, you know, it's a scary world out there. Is what happens if, you know, the Indian economy does something that means that they're not exporting these chemicals in the way that they should. I think it's unlikely, but it's something that keeps some people awake at night. The next thing is that money is short, you know, and the expenditure that we're expected to come up with, the extra money is significant. This shows the funding trends on PEPFAR. I think what's reassuring, if you look at that, you can see it's pretty much, as being used before, it's pretty much a flat line. What's encouraging is that line, that blue line in the middle, has gone up as the number of people being treated, which suggests efficiencies are being realized, as well as the fact that perhaps internal resources are being mobilized within the countries themselves. And again, using that AMFAR website, they've been able to extract this, and here you can see, confirming the fact that the amount disbursed is stable. Having said that, there are within these PEPFAR countries like South Africa, which have previously consumed a lot of resources, are getting a lot less money, and a lot of that money is being redistributed to more deserving cases. But it's an issue for rich countries as well, and here you can see, again, data from Andrew and from Andrew Phillips, looking at how much money, you heard earlier about how much money Canada is spending. This just comes from the UK, and Andrew made the comment that South Africa, who's treating over 3 million countries, is spending 3 million people, is spending 30% less money than the UK to treat 70,000. And you can see these astonishing numbers in terms of what the healthcare system spends on drugs. Again, currencies, particularly in developing countries, can be quite volatile, even in developed countries, and that creates another area of stress to try and plan for these millions of people who are going to have to stay on treatment. So what about stigma, and why is a clinician sitting here talking about warm and cuddly stuff? Well, the stigma stuff is actually unbelievably important. It's more important than the drug side effects, it's more important than the CD4 count thresholds. It's the stuff that stops people getting tested, taking their drugs, and coming back into the system. There's been some notable attempts to try and get some sort of objective level of stigma, both in South Africa, more recently from the HSRC, but we have seen even in the United States people trying to use it. But this struck me from the British HIV Clinician Society, was an HIV activist talking about his experience on Grindr, an MSM hookup site, about what he's had to deal with in terms of just trying to get a date. And I think, again, suggests that being HIV is not that easy, being HIV positive. And importantly, stigma is promoted by some programs, and I would argue that many HIV prevention programs have done this, particularly the behavior ones. It's actually a feature of many of the behavior change programs. And there's an obsession with what happens in the bedroom, often with absolutely no data to support it, and these are just some of the things that I've seen put out there: concurrency, sugar daddies, marriage, abstinence, faithfulness, the 4 C's, cell phones, clothes, cars, cell phones, you know, there's no data often to support these things, and when you do present data to refute it, it's said, oh no, you don't know what, you know, it's just heresy to even question these things. Certainly in my own country, we've spent, I was very struck by this Lancet article that came out this week with a whole lot of very senior people talking about robust accountability, transparency, and better data. But they also talked about this kind of, this prevention package without mentioning the fact that we often have non-evidence-based stuff in there that is often a fop to the behavior world when there's no data. And in my own world, we've had several studies disproving age discordance as a major driver of the HIV epidemic, yet we spend millions and millions of dollars on billboards to try and tell people that because we're a bit creeped out by older men sleeping with younger women, we therefore, we will put under the guise of HIV prevention, try and link it up. And I think it's time that people need to be braver about taking on our politicians who often are out there preaching morality when the stuff that is important, such as staying in school, which they have control over, encouraging school programs, they're not being held accountable again. And this data where Botswana is an amazing example of AIDS leadership, but this particular person was carrying on about concurrency and sugar daddies in the same time as the data demonstrating that if you can keep people in secondary school, the HIV prevalence is much lower. And I think we need to be pushing harder for these kind of uncomfortable discussions with the leadership. So being HIV positive is not easy. You know, you've got stigma, as I've mentioned, and you've put your life at the heart of this manufacturing
this conglomeration. You're at the mercy of donor and government priority shifts, and at the moment, mercifully, we haven't seen that happening in any big way. You're also interacting with a very unfriendly health system. You're often paying money to participate in that healthcare system. And certainly in my own community, there's still a lot of violence focused on people who perceive to be HIV positive. Many of you would have attended a testing session yesterday, a really exciting one convened by WHO, looking at testing processes. And one of the things we're going to have to get our heads around is that the classic facility-based testing and community-based testing is probably not enough. It took a huge amount of energy in those test and treat projects to actually get everybody to test. And I'm not sure, even then, that we can conclusively say that we've managed to get everyone into the system. That paper down at the right-hand corner, I've cut and pasted in there, demonstrated in the US it takes about 5 years on average for somebody with HIV to be successfully diagnosed from seroconversion to diagnosis. And I think this, is, for me, certainly is one of the hardest of the 90s and to get my head around. South Africa has got an investment case. They put a whole lot of very bright people to assemble the data around what they should be spending their money in. Remember, South Africa is absolutely massive in terms of the regional the resources, as well as just in terms of the burden of the epidemic. And they kind of have demonstrated that we can fund our entire 90-90-90 program with relatively, that it's already 2/3 funded. They make the point again that the introduction of antiretrovirals has had an impact on incidence. The NSP is our local target, but the thing that did make me quite nervous, and which is going to make us have to go back and look at data like this, is the elimination targets that UNAIDS has said is possible. They don't think is possible with what we've got in our armamentarium. So people who are sitting on our laurels around prevention, we need more, and if this is right. And I think that it is a kind of call to arms that simply looking at that we definitely need the vaccine. We definitely need additional interventions. This was terrifying. Also came out last week in The Economist, but demonstrates what happens when you remove the money or when a society goes into transition, and shows this incredible spike in new HIV infections in Greece with the economic meltdown that's happening and the kind of the withdrawal of services, particularly around the HIV prevention world. And I think we need to be clear that money is a major, major part of it and needs to be prioritized. We need to keep our eyes on those AMFA and other websites as to what's actually being committed. This is, I'm going to end off with just 2 or 3 slides. This is just Tim Lane's data demonstrating its incredibly high prevalence within HIV among sex workers. So we designed, this is in the heart of Johannesburg, one of the grimmest places you can possibly be in, a project where we went in, we took an established PEPFAR-funded sex worker project, and for everybody who tested positive, we offered the sex worker treatment as prevention, and if they tested negative, we offered them PrEP as a package of care. There were no inducements. This was just simply, you're here in the program, would you like to participate? And there's a whole lot of people involved with this. And it's early days yet, but we haven't yet lost a single patient. And the next quote is probably going to shock many of you, but I want to indicate how important it is, whether you're doing treatment or, but particularly when you're doing prevention, how important it is for people to feel valued within the system. And this quote, before I put it up, I just want to contextualize, is in the context of me being from South Africa, which has a particularly troubled history. They are so nice to us, they treat us like we're white people. Now, it kind of makes your heart break a little bit when you look at that, is that when you treat, I think when you dissect out the discomfort we obviously have with the statement, but the fact that when people get treated with humanity, when they get treated with respect, they will participate within these programs. You don't have to try that hard. So lastly, the challenges specific to test and treat. Chris Duncombe and colleagues have written a really reflective paper earlier this year which dissects out and talks about putting the humanity at the center of these programs. Well, we do need retention tracking programs that need to be prioritized. We don't know about what this loss to follow-up means. Often these patients are transitioning into other programs. We have to find ways to actually track that. We have to make it easier to get back into care. We have to understand that falling out of care is just a natural human condition, and that having nurses and doctors yelling at patients when they try to get back in is just not okay. I haven't put this in, but you're going to hear it again and again at this conference. We still need, particularly for adolescents and children, but we really, even for adults, the current first-line therapy is not good enough. We really need something that is more robust and certainly is cheaper. And finally, we need adherence interventions that acknowledge the fact that people go through crises in their lives, whether they get fired from their jobs, whether their relationship breaks down, whether some substance crops up.
that we're able to deal with that in a way that is much more nuanced than what we're doing at the moment. The challenges specific to prevention are that access just needs to be easier and more nuanced, that behavior change works. We know that people change their behavior if you offer them a good biomedical intervention. Waggling your finger at them from the pulpit is not going to work. And finally, we do need to start looking for additional funds for these prevention interventions. It's horrifying to me that PrEP is not available in practically any other care area of the world other than in the United States. And finally, the challenges to both of them, well, we have to start looking at poverty and social access. Now, I'm really going to be interested to look at the Temprano and the START data to see whether this is kind of the stuff which we are going to need to do. And that the kind of CD4 count discussions we're having, which while they might be important, there are other things which may be far more important to the health of our patients. We have to fix HIV testing, and we really need to get that out there. And finally, as I said, we need to start designing healthcare services that are actually designed around the needs of patients rather than around the needs of healthcare workers. Thank you very much.
Welcome back to the stage, Dr. Gail Becker.